everyone, and welcome back. I'm Dr. Cecily Havert at Northern Virginia Family Practice, and I'm here tonight with Dr. Natasha Beauvais, also from Northern Virginia Family Practice. And I'd like to, who I think most people have already all met, also like to introduce Creighton Lay, a new employee here at Northern Virginia Family Practice. He is the media manager and director here. And so he's helping us out, helping us get the word out a little bit, and also help us a little bit with the technology. But this is the Northern Virginia Family Practice Town Hall series. This is something that we started about almost 2 years ago, I think, right around the time that COVID was first, kind of descending upon us. And we were trying to find ways to connect with our patients without necessarily being in the same room. And video became a great medium for that. And so we jumped on board and started communicating through that. We've had a number of talks over the years, and took a little bit of a break last year, but we're back. Happy to be here. And tonight we're going to be talking to Dr. Ali Navidi. Very excited to have the first guest of 2022 here. Dr. Navidi and I actually have known each other for a long time, probably close to 10 years now. No, longer than that, 12 years, I think. Yeah. So Dr. Navidi and I, we've collaborated and sort of seen our careers change and grow, develop into, taking new ideas and developing and going with them. But I'm really excited to be able to bring you guys this discussion with Dr. Navidi. Just a little bit of a background. He is a clinical psychologist, and he is currently in private practice in Burke, Virginia. And Dr. Navidi focuses on mind-body issues such as chronic pain, GI problems, and also complex medical issues. And this is on top of the general anxiety, depression, grief, insomnia, other issues that we seek mental health care for. Dr. Navidi uses treatments such as cognitive behavior therapy, which I think most of us have heard of, as well as clinical hypnosis, which I hope he's going to tell us a little bit more about tonight. Dr. Navidi is also the founder of GI Psychology, which is a mental health private practice that focuses on the specific issues of GI health. GI psychology services are available via telehealth in over 20 states. So it's pretty far reaching. So Dr. Navidi, thank you so much for being here this evening to discuss a very, very interesting topic of chronic pain.
Well, I'm so glad to be here, and it's already been fun talking with the both of you. Dr. Havert has been my go-to doctor in terms of referring patients to when what's needed is somebody who is very psychologically minded. We need a doctor who's psychologically minded, really good with rapport, really good at connecting with patients, and because she's just so darn likable.
Well, thank you for that. I'm glad.
No problem.
I'm glad that I can connect with patients, and also I feel that I can connect with a lot of other collaborators and professionals in the area. So that's great. So tell us a little bit about yourself. Should I call you Dr. Navidi, Ali?
I don't know, whatever everyone else.
Whatever. Okay, we'll go back and forth maybe. So, but why don't you tell us a little bit about, I kind of said in my words what your practice is all about. Why don't you tell us about your practice and what you enjoy treating and what brings you joy from that?
Yeah. So I'll go back a little bit in terms of I got into psychology because I was just fascinated with clinical hypnosis. And I was fascinated with the idea that there's this set of techniques that can allow people to access abilities and to make changes that are not typically available. And just, I started exploring that, and I said, you know what, let me get paid for what I love to do. And so that was kind of my journey. And then I kind of fell backwards into working with mind-body issues because hypnosis is this amazing tool to access that. Because it allows people to access these other, kind of states and other parts of the brain other than just the kind of conscious mind.
Mm-hmm.
And of course, there's also, like I think we've talked about before many times, is there's a tremendous body of research showing how effective hypnosis is for GI issues, as well as for chronic pain. And so I just kind of started working with these GI patients, and it was just so successful. It's not what I intended, but before I knew it, it was about 80% of my caseload. And we're working with people with IBS, and we're working with people with all kinds of functional pain and nausea and reflux.
Mm-hmm.
And that we keep getting referrals. And then so doctors are getting to know me. And at a certain point, I was at a choice point of, okay, I'm out of space and I really love doing this work. What do I do? And so I found another psychologist who kind of shared the vision of, hey, we've got this treatment for GI problems, validated, empirically validated, tons of studies over the last 30 years, works really well, barely anybody knows about it, and there are very, very few people trained to do it. Let's create.
That's just it. Barely anybody knows about it. Why is that there are so many symptoms for which the treatment is really well understood by very few people, and including doctors? I'm only learning about this after being 20 years in medicine.
Yeah. You mean the GI side of things, or just hypnosis in general?
In addition to that, alongside both of those, just the profound amount of somatic symptoms people can have, physical symptoms, the physical symptoms that are kind of triggered by our brains that make people afraid, and they generate lots of questions for doctors. They generate lots of huge workups, and then we wind up saying, well, it's not these important things, and so then how do we fix it? And for 20 years, I haven't really well understood exactly how to help people get to the bottom of how to fix what they had that wasn't serious. It wasn't a serious life-threatening thing, but it's very, very life-altering.
I don't have the answer. I have ideas. I think for a long time, I think it was very stigmatized that somebody could have something physical and that there was a psychological component to it. And I think that was just thought of in a very negative way. And now we have a much more nuanced understanding that the body doesn't stop at the mind, and the mind doesn't stop at the body. That there's this crazy thing called the neck, that we have a whole body, and it's always communicating with itself in various complicated ways. And so the idea that there's a mental component is slowly being understood in as more of a standard, just in terms of the name of like IBS, for example, irritable bowel syndrome, used to be under the category of functional GI disorders. And functional meaning, hey, we can't find any reason, the function of the system is messed up, but there's no organic cause. Now the name has been changed to a disorder of gut-brain interaction. And we talked a little bit about that. And that's such a better name for it, because it's saying, because functional kind of implied, there's nothing wrong, right? Whereas disorder,
it's not working right. Yeah.
But it's functional, but like there's nothing actually wrong with this person. So I don't know what they're complaining about. Like that was kind of the undertone of it. I felt. But now disorder of gut-brain interaction, there is a disorder occurring, and it's more subtle. It's more, I use the metaphor of it's a software issue, not a hardware issue. The two parts of your software are kind of not communicating well, causing this disorder in your GI system. It's a real problem, and you're not making it up. And there is a problem there to be fixed. And now we understand it well enough to start to be getting to the dynamics of what caused the problem. I don't know if that answers the question. Go ahead.
Yeah, no, I think that this is a good segue. I mean, we've been talking a lot about the the GI system, but but I think that we can, kind of make some correlation also just to what pain is also. And I think that why don't we kind of dive in a little bit and just discuss, well, what is pain? So, Dr. Navidi, is this, I know that there, a lot of times we think of pain as, we cut our hand, right? And our hand really, really hurts, right? And we say, oh, well, the problem is with my hand. The pain is in my hand. But I think what we're starting to, or maybe starting to think about things a little bit different, or realize that even though the injury is in the hand, the pain is actually being generated from our brain. Right.
Yes.
So let's talk a little bit about thinking about turning pain sort of upside down or into our, what is this? What is this way of thinking?
Yeah, I think you set me up perfectly, because that's kind of the nice little short thing that kind of encompasses everything. All pain is in the brain. All pain is in the brain. And if it is in the brain, what does that mean about pain? And so from that point, we can go in a lot of different directions, because at that point, pain becomes much more complicated phenomena. Because, if you want to go in the neuroscience aspect of it, we know that pain, before you're even conscious of your pain, it's being processed in multiple parts of your brain before it even gets to you. It's being processed in terms of the sensory qualities. It's being processed in terms of intensity. It's being processed in terms of emotional content. It's being processed in terms of meaning, all that before you even become aware of it. And depending on your emotional, mood at the time, depending on the meaning you give to the pain, it's going to come and it's going to be displayed to your conscious mind in different ways.
It's sort of like the what is it, the biopsychosocial, sort of looking at it in that model. So there's the biology, there's the physiology of the bleeding, lacerated hand, but then there's the the psychological impact. What was going on before, what was going on after, what mood were you in when this occurred, and then also the social, what other external stressors do we have? Are we living under stress? Do we, there's so many other aspects, and those three things. I mean, we focus so much on, I think, the biological, on the lacerated hand causing the pain, and I think we forget almost about 2/3 of the other aspect that could be, creating this sensation or this experience, right?
Well, that just made me think of this example of pain, which I don't know, makes me smile. Which is, let's say, looking at the social aspect of pain, right? Anyone who's had a little kid, like a little toddler, and the toddler's running, and then the toddler trips and scrapes their knee. What does the toddler usually do? The toddler looks up and looks at their parent, if their parent is there. And depending on how the parent reacts, the toddler is going to react in different ways. So if the parent looks scared and, oh my God, the toddler might start to kind of get a little teary and get a little upset. But if the parent is kind of like laughing, low key, oh, good job running, you were so fast, the toddler is going to react very differently. And it's because of that very powerful social component. What's going on around you socially has a massive impact on the psychology of what's going on in your brain in terms of how that pain is expressed.
And I think we have to be careful though, because, I know that, we've all heard the expression, it's all in your head.
Ooh,
Right.
yeah,
And I think that's also something that's maybe stigmatized and, maybe, even taken validation away from people's experience when they are, because people do suffer from all types of pain. Right. There's chronic pain and, just whether it's arthritis or it's fibromyalgia or it's, abdominal pain or whatever it is. That pain is real. And I think I just want to set the groundwork by saying that even though we're talking about how the brain plays into this pain is real.
yeah. And that's important because the phrase "it's all in your head," that has this implication that maybe it's your fault in some way, that you didn't do something right, that it's not real.
Mm-hmm.
Pain is absolutely real. And I've treated so many patients with different kinds of pain. And just because that there are psychological things that you can do to improve your pain doesn't take away at all from the reality of it and how difficult it is to have pain. So that's a really good point, Dr. Havert.
Yeah. And I think the point is also just anything we can do to gain more control over pain and quality of life, I think is I think what we're trying to get at by talking about these maybe different ways to think about pain. So I just wanted to interject with that.
And that goes back to the original question, like kind of what is pain? Another way you can answer that is, pain is a danger signal.
Yes.
Right. And I think that's a really important concept, because once we understand pain as a danger signal, that helps us understand how we can begin to treat chronic pain.
So let's talk about that a little bit. Yeah. Go ahead, Natasha.
That was my comment too. Yeah, let's go into that a little bit more. What's that feeling if pain is a danger signal, but you have it all the time, then how do we reinterpret that danger signal?
Right. And we can go, of course, really deep. There's so many avenues to understanding what that means, but to kind of bypass some of that explanation of the dynamics to say, okay, well, if pain is a danger signal, and if chronic pain is a danger signal that is going off sometimes when there's no longer any danger, right? Sometimes the area, maybe there was an injury and then the injury's healed, but the danger signal is still like beep, beep, beep. There's danger signal still going off. So there's still that pain. Then a lot of the treatments involve introducing safety into the system. How do we retrain the system to kind of slowly let go of that danger signal and to experience a sense of safety? And that's, I think, often one of the guiding principles in terms of like working with chronic pain is the more the patient can begin to feel safe in various ways, the better their outcomes will tend to be.
So when you start to work with someone and they come in with their version of GI symptoms,
Sure.
do you give them like the table of contents about how this is going to go first? Say like, really what we really need to do is introduce safety into the system, and then we'll be able to help you modify. And, I've heard you before describe the volume knob, turning up and turning down your symptoms.
Yeah.
Or do you just sort of start by taking a whole history and really hearing what you have to start with the history, but once you've gotten the history, do you then just kind of move into direct treatment, or do you give people kind of a, hey, here's how this can go?
I think the phase is, for me, it depends on how complicated I think the case is. I'm working with someone right now who just started, and they've got a complicated, family history leading up to the chronic pain that they have. And the chronic pain is complicated because, like with a lot of cases, let's say it's a very straightforward case of IBS. They've been checked out up, down, left, and right. Everybody's very certain there's no organic problem, versus someone who comes in with chronic pain in multiple systems. They're having trouble with their eyes, they're having trouble with their stomach, they're having chest pain, they're having this, and there's a lot more uncertainty. So in a case like that, you want to spend a lot more time getting history, because I think a key part at the beginning is just making sure that they feel that you understand what they're going through. I think a lot of times they don't get that. They're just kind of shuttled around. And so just getting that understanding. And then like you said, I would go and start to give an appropriate level of understanding of, okay, this is the model. This is what I think is going on here. And this is how I think I might be able to help as a psychologist. I don't want to get into that until they feel that I really understand all the pieces involved.
When someone comes in with a myriad of emotions, I mean, maybe you could just describe the types of symptoms that are common in your practice that people come in with, and how those may or may not be tied to emotions, directly tied to emotions. And maybe people have insight about that, or maybe they don't. But give us a little bit of an overview of kind of what are people suffering with when they're seeking your help.
I think that's pretty broad. We see a lot of variety, and so it's not. We see the what we would call the disorders of brain-gut interaction. So that would include IBS. So they're feeling, stomach pain, defecation is altered. They're also often feeling kind of bloating, uncomfortable. There's dyspepsia, which is more kind of the upper GI problems. There's acid reflux. They might come in with that. There are patients that come in that have chronic nausea. So they're kind of just often feeling nauseous, or even constantly feeling nauseous. We're seeing people who not related to an eating disorder that are vomiting frequently, not because of like an eating disorder dynamic, but because of other factors. And that's just kind of, and then there's kind of the IBD stuff. So that's like Crohn's and colitis. And there's often a lot of symptoms associated with that we can help patients with. And that's just the GI related stuff. Then there's the other kind of chronic pain stuff that we also see.
I think also, we're talking about how emotions might, show themselves as physical symptoms. I mean, the other thing that I kind of want to bring up is, some examples, just normal, just to kind of normalize this a little bit, because we don't always necessarily have to experience pain or unpleasant symptoms necessarily when we're having emotions. I mean, think about when we're excited about something, we'll feel butterflies in our stomach. Right. So, I mean, I think that probably it's also just to say, well, let's think about an emotion, something that we're thinking about, and then just pay attention to what's happening in our body. Sometimes also when we get nervous, there's sweaty palms. So, I mean, I think that's also an example of how an emotion or a feeling, or even maybe even a memory might have a connection with something physical happening in our body. So we experience this all the time.
Yeah.
Right.
How about your heart rate pounding?
Yeah.
Yeah, anytime you're excited or nervous or scared, there's a physical change in your heart rate. Why? Because we were created that way. We evolved that way so that we could run away from scary things and defend our children against enemies. And so that's healthy. Like a lot of those butterflies in the stomach or or your heart pounding started with initially a healthy response, that we developed over eons to survive. And then it gets kind of overdone.
Yeah, and I think that's kind of, I mean, some of what we're talking about here. It's just that these triggers that aren't necessarily always there, suddenly that fight or flight, or that hypervigilance gets sort of turned on, it can't get turned off. And so what are things that can cause that to happen?
Well, I
Ali?
think kind of the classic would be the good old panic attack, which is they're terrifying for patients, and they can take so many different forms. So I've seen just over the years panic attacks associated with a patient's breathing. So they notice some disturbance in their breathing, they get worried about it. That anxiety makes the breathing worse. They get more worried, and then you get into this spiral where people are hyperventilating, and but you can also have a panic attack around chest pain and tightness. You can have panic attacks around sweating. You can have panic attacks surrounding pretty much any physiological function that you can notice, and which is and that illustrates the power of this mind-body connection, which is what we focus on, we will tend to amplify. And that can be good and that can be bad. I was talking with someone the other day who's a musician, and they've got perfect pitch and they've trained as a musician. And when they were talking about when they're in the mall and they hear music, it almost makes them like they literally feel physical kind of pain hearing those, that bad music to them. And so that's an example of focus and sensitivity. They've developed that sensitivity, and that can also happen in a negative way too. So as people focus on their pain, or as people focus on their breathing in an anxious way, or as people focus on some GI symptom, it will tend to amplify it, and it will set up a feedback loop.
Ali, we just see this all the time. I mean, Cecily and I could the three of us could share 100 stories right now. And so I think we could kind of go with that about, how do we all experience that, even ourselves, how do you think about it yourself? And then you end up, I can't fall asleep. Well, boy, I really can't fall asleep. And then, we can all take ourselves into a cycle with that. And I'm also curious about the absolute opposite, where people come in with a physical symptom that is because there is an emotion that hasn't had a place to be voiced or named. And, so you mentioned people who have chronic daily nausea or chronic daily reflux even. And we doctors are looking for a reason. Why do you have reflux or vomiting? You mentioned I recently had a patient with the same. And we're treating that with physical treatments. We change the acid levels in their stomach and we test them for H. pylori. But what about those people who really have nausea because they don't have a, as you said, organic problem? How do you tease that out? Even like, let's say you have a patient who's been through a workup, they're comfortable that their workup is pretty good, but they don't have an insight about an emotional aspect of their physical symptoms.
Well, this is where hypnosis comes in. I will frequently have patients over the years that will come in and say, hey, I have these symptoms. I don't think it's related to anything. and just to keep it simple, let's say it's GI related, or you could, let's just say it's GI related. So, and I don't know why I'm having this. I'm not feeling anxious in any way, and so you don't have any, you can't do anything with that with traditional talk therapy. You can kind of ask some questions, but if they don't have a lot of insight, but there's very, very cool techniques that you can use with hypnosis to teach people how to access some of that kind of deeper knowledge of their own underlying psychological issues, emotional issues that they can't get into, they don't have access to at a conscious level. I'm routinely using these techniques, so met with
can you just tell us a little bit hypnosis? What because I mean, I think people, when they think hypnosis, they think it's some sort of stage trick, right? And you're going to control them, you're going to tell them what to think, you're going to tell them what to say. But can you just give a little bit of, just before you go into just when you use hypnosis, how would you explain it? That's
a very good question, because I'm talking and assuming everybody understands hypnosis the way I understand it. So there's two types of hypnosis. There's entertainment hypnosis, and then there's clinical hypnosis. And everybody knows entertainment. Sadly, everybody knows entertainment hypnosis. So I don't really need to get into it. Mind control and crazy things happening, sometimes magic, and in the movies, in shows. And I think, for Dr. B's initial thing, like, hey, why don't more people know about this stuff? I think for hypnosis, people don't know about it because entertainment hypnosis kind of clouds everything. Why don't we know there's so much good research on GI related symptoms for hypnosis? Because everyone thinks entertainment hypnosis. So what is hypnosis? What is clinical hypnosis? I'll do the super short explanation, which is just humans go in and out of trance.
Just normally, right?
Yeah,
throughout the day. Mm-hmm.
Yeah, we daydream. I'm driving. I'm listening to my, book on tape. Teenagers, going on social media. Trance is always is happening all the time. Runners getting into the zone and then just not feeling any discomfort as they run. Trance is happening all the time. And hypnosis is just teaching someone how to go into trance deliberately rather than accidentally. And when people are in trance, they can do some neat things. Athletes routinely go into trance while they're playing their sport. I was a soccer player, and I had tons of games where I would get done playing and I'd have scrapes and cuts and I'd be bleeding, and I'd be like, wow, didn't notice any of that. Because when you're engaged and you're focused in the game, you go into this very externally oriented trance where your brain has the ability to turn down the volume on the stimuli that you're getting, because it's saying, hey, this is more important. And so trance is something normal. So teaching people how to use hypnosis is not terribly hard, because if I just sit and talk with someone for 45 minutes, at some point they're even going to naturally go into trance, especially when I'm talking. I'm sure people listening to me right now, there's one or two.
A good number of people in trance right now.
As we speak.
Yeah.
And so that kind of tosses out all the myths about hypnosis. Like when you're daydreaming, can someone control your mind? No, they can't control your mind. Nothing magical is happening there. But something very interesting is happening. And that's a natural human function that most people don't know how to access deliberately. And that is the cool thing about hypnosis. I get so fired up about that because Oh, go ahead.
No, I was going
Okay.
to say, so it really is, using hypnosis is one tool that we can use to kind of turn the volume up and down on
Yeah.
that experience that we have as pain. So can you give an example of somebody who might have had, either like severe headaches, or maybe, I don't know if, or I mean, I know you do a lot of GI
Yeah.
work, an example
Yeah.
of
No,
how
headache.
and maybe they don't understand why, or, how hypnosis helped you get to some relief or
Well,
understanding.
a very, very common example is, headaches are a very common problem, that go along with a lot of other problems. And so I've seen a lot of patients with headaches, chronic headaches, and once they're trained to use hypnosis, they'll frequently come in, Dr. Navidi, I don't know if I can really do much today. My head is killing me. Go into trance, turn down the volume of the headache, come back out, and routinely going from 7 out of 10 in pain to often like a 1 or a 2, and they look different. That's the really cool thing. So again, that's an example of that mind-body connection, is that what we do in our mind can very powerfully affect our body, and trance is kind of like an amplifier of that effect. And so there's a lot of uses for hypnosis in terms of this treatment. And just one of them is giving people more control of their experience of discomfort.
Mm-hmm.
And
That's so powerful. Yeah, to even imagine having control, to even imagine that it could be
yes.
possible.
And if you think about, so you've got this chronic pain, and of course, you have anxiety and stress and probably frustration about it. Just giving them even a little bit of control is a massive change psychologically, because once you feel, because a big problem psychologically is when you feel out of control. That's a terrible, terrible place to be. And that's a frequent place that patients with chronic pain find themselves in.
Which just puts you into a panic attack. I mean, there's a symptom that's out of control, and then there's an experience of exacerbation of that symptom because of focus on that symptom, because there's no control.
It's sort of like the danger, alarms are going off. I'm out of control. I'm never going to be able to feel well again. This is, and it's just like, and then the limbic system, or the emotion, the fight or flight starts to kick in. And this kind of, it goes along the lines of the idea of central sensitization a little bit. I mean, can you tell us a little bit about that? I mean, I think I've read about this, and I think we've talked about it a little bit, but can you tell us a little bit more about that?
Well, I try to break it down simply, and I was talking with someone about it earlier today, and I feel like so central sensitization is basically the idea that the central nervous system can become sensitized to something. And sometimes that sensitization can occur in terms of anxiety. Sometimes that can occur in terms of pain. And so it's the idea that the brain has learned to expect pain. Let's use pain as an example.
Mm-hmm.
Central sensitization is that, so the brain has learned to expect pain. And that's this concept of predictive coding, which we don't need to go into. But it's predicting, I had pain yesterday, I'm going to have it today, and then over and over. So it's learning that it should expect pain. And so when the brain expects something, it's going to focus on it, and that focus can also amplify everything. Because if you think about it, it's like looking around for pain. And so what can happen is then stimuli that are neutral can then be perceived as pain. You could imagine like there's somebody sitting in a, they're kind of guarding, and it's night out. And so they're really nervous and scared, and they're looking for enemies, you ever hear the term jumping at shadows? That's kind of what we're talking about, is it can make the mistake of perceiving things that are not necessarily painful as painful. And then painful things become more painful because it's looking so hard for things that it's going to amplify everything. It's going to amplify everything.
So you're talking about kind of learning a neurocircuit.
Yeah.
And in this case,
strengthening it, learning it, and then strengthening it because you use it over and over and over again. Just like that song that plays in your head that isn't really happening. I love this example. We've used that before of just sort of like, well, what does that mean? You know, like, well, you hear a song playing, right? And you're like, oh yeah, so that's playing. And then a few hours later, something happens and it pops back in your head. And to you, it feels like it's really happening. And what that is those are some neural circuits that are replaying that song. And the same thing can happen with physical symptoms too.
Right. Or have you ever been on a really long drive in the rain and you get out of the car and you feel like the windshield wipers are just still going? It's like your brain is kind of used to accommodating for windshield wipers.
Or when you get off a boat and you still feel like you're moving, right?
Yeah,
your body has sort of created these neural pathways. Like this is what's happening. And so it's fascinating, but sorry, I didn't mean to interrupt. We're talking about
I think that's a great tack to take, because we're talking about, I mean, Ali, you're talking about how does the body, why would any of us over focus on a symptom? And you're describing this experience of learning that this is happening. You're learning to be aware and learning to notice. You're unconsciously learning to be aware and notice that these things are happening. And that is an example of neuroplasticity, like our ability to change our brain circuits. And that's an example of it happening in a way that's not good for us. And neuroplasticity can also be used in a healthy direction to retrain our neural circuits so that we won't be constantly living with that symptom that our brain has kind of grown to expect.
And it's teaching the brain, because before it was always scanning and it's always looking for that symptom. And what we want to do is retrain the nervous system that there's safety there. So it comes back to safety. The assumption with central sensitization is that there is danger in that area. So you can get sensitized to your gut, you can get sensitized to your head, you can get sensitized to any part of your body, to any symptom, nausea. And when you can teach the nervous system and the person that they have control and that there is safety, and you teach them that over and over, just what Dr. B was talking about, that neuroplasticity is then working in a positive direction.
Talk about safety more. I feel like that's a massively powerful tool that we don't realize the importance of.
And so safety can come in so many different ways. We were just talking before this kind of started about humor. And humor is a form of safety. When you're joking, underneath the joking is a sense like you don't see people joking when they feel they're in danger. So joking is kind of one thing that creates, there you go.
Oh no, you did it.
Yes.
I just don't want you to take me too seriously.
Well done. So now I'm just feeling a lot safer right now.
Oh.
But no, I can even feel it just laughing like that. I'm like, I can feel myself even relax.
Right. It puts us in a totally different mind space. Yeah.
Well, I think that, and I think that also when we kind of go back to that concept of turning the volume up and down, I think that humor and laughter and letting things out is somewhat of a release. It's like letting this, like a teapot that's about ready to, like explode or whatever. You're letting that out. You're laughing. You're letting out emotions. You're relaxing. And then so that kind of makes us feel a little better afterwards, I think, when we laugh.
Absolutely. So. And that's a whole other part, is kind of repressed emotions and psychological conflicts, when you can get them out to the surface, when you can express those emotions, when you can pull those conflicts out and talk about them, then you're kind of releasing that and you're moving towards safety. When there's these emotions that aren't allowed to be expressed, that doesn't feel safe.
So how does trauma or past trauma, even, childhood trauma or we can talk about any form of trauma, how does that impact pain or the experience of pain?
Well, we know, from the studies they've done on adverse childhood experiences, so they call the ACEs study, that there's a clear correlation between traumatic events or adverse events, especially in childhood, and developing chronic pain of various kinds, as well as developing various physical problems later in life. And so think about trauma that occurs at a young age. The child is learning, and children learn really, really well that their environment is not safe. And kids learn it so well that they then take it with them the rest of their life. And so unless they are able to process that trauma in some way, to work through it, whether on their own or with help, there is that kind of feeling underneath everything that they're not safe, that their situation is not safe.
So it's like their body is constantly scanning for danger, right? And I think we
find externally, right? That's anxiety. I'm worried about this. I'm worried about this. I'm worried about this. But they also internally, they're finding danger in their body. Oh my gosh, what's going on here? And as we already know, that danger sense is going to amplify what they find. And it's going to create a feedback loop.
And just to kind of go back again, pain equals danger. So, if you think about it, these are primitive reactions that are meant for survival, right? Think about when you put your hand on a hot stove, right? Obviously your body knows that to continue holding your hand on that hot stove, you're going to have some tissue damage. It's not good. So you create a sensation of pain to basically tell your body and your muscles and your hand to move, right? So it's danger. And so I think, so that's also where pain comes in, is so dangerous feelings of danger, we start to create an association also with pain. So I think that I don't know, if this is something that comes into play when we're dealing with chronic pain, I would think at some level.
Yeah, because if you are always feeling in danger, then it just makes sense why you're more likely to develop chronic pain, because then little sensations that are being sent up to your brain from your body, they're more likely to be turned into pain because they're being looked at from the lens of danger. And we know danger, kind of pain equals danger, and danger equals pain. So what you see is when you get someone to, start laughing more, or teach them how to relax, or help them to process some of the underlying issues that they have that are causing this kind of constant sense of danger, that their experience of pain decreases. And that's pretty real. And it's like, I was just talking to someone earlier today about that. We haven't even directly addressed their pain, but we've taught them how to create a sense of safety and relaxation, and then access that state throughout the day whenever they need it, right? Very quickly, because we help them create a conditioned response so they can access that sense of relaxation and safety. And so just doing that, they're using that technique all throughout the day, and their pain is bothering them less.
So it's almost like you're desensitizing. I mean, that sounds like a technique of desensitizing yourself to pain, because you're kind of you're showing that there's safety, this
Yeah.
yeah. I mean, I think also, sometimes, when you are in a really dark room, and you suddenly turn on the lights, it can be really, really, bright and painful, and that's not any good. So, but I think the gradual, like turning the lights up a little bit here, you get used to it, and suddenly
Right.
you get to a point where you can tolerate the bright lights, and it's
Yeah,
not painful anymore.
that's a great analogy, because if you never expose yourself to the light, you'll never adapt to it.
Yeah.
But if you do it too quickly, it's overwhelming.
Because you're not safe. You're not feeling safe when that happens, right? I mean, that's yeah. So that's yeah. Well, so I mean, we're about we're getting close to the end, and I don't know if we want to open it up to any questions at all. I don't know. Creighton, have there been any questions, or anybody, have they posted anything? Does anybody want to post anything?
I'll take a look at the chat. We have both a chat and a Q&A.
Okay.
And, just one comment, Cecily, that you are fantastic, which I completely concur.
Oh, I don't see that comment. I guess it's
and then here's a person who had a dental procedure. Let me see if I can read this all. Today I had a cavity filled and I had a hard time getting numb. The dentist tried a different numbing agent that he told me was stronger. Psychologically, I relaxed more because of this. He said that he was able to see how relaxed I became immediately, and I believe it reduced my sensation of pain, never having issues throughout the filling process. So was the medicine much stronger, or did I believe that it was, and then I relaxed and felt less pain?
Placebo. We can will ourselves to feel better. I don't know. So I don't know, Dr. Navidi, sorry. Do you want to comment on that at all?
Yeah, absolutely. Because we're talking about the power of belief, right? When we believe, and there's placebo and there's nocebo, where belief leads to some negative outcome. And so you could see in that's a beautiful example of they believed that this new medication was going to be different and it was going to give them a good result. And so they felt safe. And because they felt safe, their body stopped scanning for pain, and they probably were focusing on other things.
So the spotlight was taken off that neural pathway that had developed for the drilling and the pain. The spotlight that was on that tooth, suddenly it could dim a little bit.
That's a great analogy. And so they turned off the spotlight, and they were focusing on, how long is this going to take, or whatever it is that they were focusing on. And they were able to do that because that belief that they had about the drug enabled them to feel safe.
Right. And there's so much science about this, about what our beliefs cause us, how our beliefs cause us to respond to medication, and how our belief about whether we're going to get better from anything, medication or not, changes our outcomes. Ali, there's a few specific hypnosis questions, which are questions certainly Cecily and I don't have the expertise to answer. What part of the brain is active during hypnosis? And is hypnosis similar to meditation or different?
Great questions.
So in terms of the brain and hypnosis, it's interesting that they still at this point, even with all the studies that have been done with imaging and hypnosis, and there's been a good number, they still have not figured out the hypnotic state, what brain areas. Now, what they have found is, for example, with pain, and we don't have time to get into this, but when they're using hypnosis on pain and they're imaging the brain, they find that different hypnotic suggestions light up different areas of the brain. So if I give suggestions for changing the quality of pain, so it's, instead of a burning, it's going to feel like a tickling. that lights up a different area of the brain than if I give suggestions about intensity of the pain. Or if I give suggestions about the emotional reaction to pain. It's going to feel boring. It's not going to be interesting to you. That lights up a different area. So we know that when we're using hypnosis for pain, we're directly changing the activity in different parts of the brain.
And maybe are you spreading it out also? It's like maybe it used to only be on one part that was only feeling the pain in my back or something. And then if I spread it out and I notice, is it tickly? Is it burny? Is it, front or back or left or right? Then I'm like, I'm having to work that sensation in different parts.
There's other processes starting to be engaged rather than just the spotlight on the pain like that it's, maybe you're kind of spreading things out a little bit, and that kind of again, it's sort of like the spotlight. So
I think you're right. It's very complicated. And this is where we get into the concept of pain being very complicated phenomena. It's not simple. It's not like pain goes to the brain, done. It's like goes up to the brain, and then a lot of stuff happens there. And the neat thing, why I get so excited about hypnosis, is that it empowers patients to be able to, in a way, take more direct control of their brain in ways that had felt not within their control before.
Yeah, just like accessibility and control. I love that. And so
really,
I'm sorry, Natasha, but just to piggyback the meditation. I mean, what parts are there? Hypnosis, meditation, are there similarities with those two?
Very similar. Both are actually utilizing the trance state. It's just what we're doing with the trance state. So hypnosis is much more kind of directive, and we're kind of going after certain things. Whereas meditation, if we're talking about, for example, mindfulness meditation, that is building a cognitive skill of like kind of being able to increase your ability to have that meta awareness, right? So it's like you're going and focusing on your breathing, and then you get distracted, and then you bring yourself back, and then you get distracted and you bring yourself back. And each time you bring yourself back, you're building that meta awareness where you're able to kind of track your own mental world and make course corrections, which is an amazing thing to build up, and everybody should be meditating. Because it helps with their mental health, it helps with their physical health. But meditation is kind of a more general thing that you're building for yourself, whereas hypnosis is more kind of directed, like, oh, we're going to go after helping someone with their anxiety right now, or we're going to help them process this trauma, or we're going to work on giving them a skill for managing their pain.
And talk about, there's another question in this chat about, is trance a subset of intentional dissociation?
So I would kind of flip it around and say that disassociation is an aspect of trance. And then there are other aspects of trance in addition to disassociation. And that gets into the topic of, what is dissociation?
Yeah. It's a little different, isn't it? I mean, dissociation is kind of in response to, trying to find safety in a place that's not. I mean,
well, dissociation is kind of like stepping apart from yourself.
Okay.
And it's a natural cognitive function that anyone can use, and we do use, but that often in patients who have gone through trauma, it becomes used in kind of this reflexive negative way. But disassociation is neutral in the sense that it can also be used in healthy ways. And I could talk a lot about dissociation, but it is related to trance, but kind of dissociation is something that happens in trance.
They're not the same thing entirely.
Yeah, they're not the same thing. Yeah, but that's a very sophisticated, complicated question.
Thank you for that sophisticated, complicated question.
We have the greatest audience.
Yeah, we'll just do maybe 2 more questions and then wrap up because we're at 8 o'clock. One question is, would hypnosis have any application in autoimmune disease?
So I would say that we know at the very least that stress and anxiety are not good for patients with autoimmune diseases. And that at the very least, giving someone tools in terms of how to relax, how to deal with stress better is in general going to help someone with an autoimmune disease. Now I've definitely heard kind of case reports of people doing more with hypnosis and autoimmune disorders. That hasn't been an area that I've focused on a lot, so I can't speak directly to it. But I've definitely heard reports in terms of like things like psoriasis as an example, and other things where hypnosis has been helpful, other autoimmune disorders.
And certainly there's lots of data about people working on the neuropsych synapses that can be concomitantly active along with an autoimmune process. And a patient might have both things. You know, they could have an autoimmune illness and stress that is exacerbating their experience of that autoimmune illness. And I think if we're able to really give people the support that that would benefit them on both sides of that equation, people get a lot better. If we only are treating the autoimmune disease with immune suppressants or immune modifiers, the neuropsychiatric aspect doesn't get treated, and then it's always kind of influencing that autoimmune process. You two are both nodding, like you've seen it.
Yeah, I mean, I think that actually, you know, even medical education doesn't necessarily teach this. I mean, Natasha, did we come out of medical school knowing this? I you know, this the psychological impact on disease. I mean, we can't separate the brain from the physical symptoms or, you know, or anything that's happening in our body. Right. But I don't think we're necessarily taught, and society isn't necessarily taught to value the, you know, the role that society and psychology has in how we experience and the severity of our medical illness. I mean, we could probably make the same argument for hypertension or diabetes. I mean, you don't experience these physical symptoms in a bubble without those other experiences happening. Right. And I think we really need to start to incorporate the full biopsychosocial, you know, approach to treating disease in order to, you know, treat it effectively.
Yeah. And I think something that really makes sense to you and I, and a way that we constantly practice is to really bring that aspect of the treatment and the diagnostic equation in the beginning. Mm-hmm. So instead of saying, well, I have nausea, and we say, well, go take some Zofran, which is a nausea medicine, or, go take a nap. You haven't slept enough and it should go away. We're saying, okay, well, from day one, part of the piece of nausea it may be a real, contagious illness, or it may be like a medical surgical problem, or it may be a psychosocial manifestation,
or maybe it's all of the above.
And maybe it's all of the above.
Does it have to be an or?
Yeah. And I think the most important part is, very good point. It's not an or, and that we don't leave that for the end. It's not like, well, if all else fails, maybe it's in your head, which brings me to the next question, which says,
I wanted to close on this because I think I just want to keep pounding. Go ahead, pounding this away.
Yeah, sure. So back to the phrase, it's all in your head. Mm-hmm. This participant says, this has merit because we know essentially pain is driven from the brain, but is there a way to word it better where it doesn't seem to the patient that we are just writing off their pain?
Yeah. And I would say, I I like the phrase all pain is in the brain. And when I say that, I'm thinking to myself, well, and the brain is part of the body also. And so, all pain is essentially in the body, because that old phrase of it's all in your head, it conveyed a sense of unreality that doesn't capture really the experience. And the experience is that pain is in the brain, and the brain and the body are intimately connected all the time in everything that is happening, to the body is being reacted to by the brain, and everything that's being reacted to by the brain is being experienced in the body at the same time. So that's my shot at it. I don't know.
Yeah.
What do you
and,
two
and
think?
being human is to have pain. I mean, it's universal. We all experience pain. It's part of our humanity. And, hopefully, I think, as we step away from tonight's talk, hopefully we've all learned a little something, or maybe a different way of looking at it, a different perspective, I think is all that we were getting at here. So, I mean, I've learned a lot in the discussions that we've had leading up to this talk. Dr. Navidi, thank you so much for coming this evening, and I'm going to say continuing this conversation. I think we're going to continue to have it afterwards. But I've really enjoyed it. So
me too, and really fun to prep the call a week ago. We were having a great just learning experience that so much of what you do really resonates with what we do, and frankly, it feels like my new learning agenda for this decade. Like for 20 years, I didn't know that much about this, and now I feel that this is essential, and probably, certainly myself. I mean, this is not a presentation about other people. Cecily said, to be human is to have pain, and to be human is to have neuropsychiatric symptoms. Like we all have them.
Mm-hmm.
And so to recognize that, like in the beginning of every conversation, because it is normal, like you said, Ali, so much of this is can be a normal state, and then it gets into a dysfunctional escalation, and then we have to learn different ways of tuning it back down into a normal state.
Yeah, and I like what you said. To have pain is to be human, and to be human is to have pain. And I was thinking that yesterday, that I had a little bit of a headache, and I found myself kind of like clenching about it, like internally clenching, like I don't like this. And then I kind of stopped and said, okay, let's just be present with it. Just kind of notice it with a curious sense, not a danger sense. And it was really neat, because as I did that, I could feel the sensation altering, shifting, lessening. And I wasn't even trying to necessarily make it lessen. I was just approaching it in a different way. So getting back to our talk, this was super fun for me. And I really appreciate this opportunity to just talk about this stuff with two professionals who really know their stuff. And just interacting with the two of you has prompted me to even be learning more. Just some of the resources you sent me, I'm checking them out, saying I'm learning new things too. So I'm not like the one who knows everything. I'm still discovering things and kind of like, oh, this is really neat. I need to learn more.
Yeah.
And I hope that as we continue with our town halls this year, we'll continue to learn more about lots of different things. We're going to be trying to do these monthly, and since next month is February, which is also Heart Health Month, we're going to be featuring a cardiologist to discuss some aspect of heart health, of course. So stay tuned for that. And I think, Natasha, you were going to introduce one other surprise opportunity that we have coming up.
Yeah,
here.
So next week we're going to be bringing Dr. Paul Sachs to you, who is a quite famous infectious disease physician. He's currently head of infectious disease at the Brigham and Women's Hospital in Boston. He's a Harvard professor. And when we brought this up to Dr. Zweig said, boy, that's just about one notch away from Anthony Fauci. So we hope you'll join us in listening to Dr. Paul Sachs, which will be an interview brought to us through Special Docs, which is a group that we work with. And we're really looking forward to being participants in that presentation as well. Creighton, I think that's on the 18th. Is that Wednesday the 18th? Yeah.
Tuesday the 18th. And
okay.
Tuesday the 18th. And it's going to be a discussion about COVID, if we haven't already mentioned that.
Thanks.
Yeah, the elephant in the room. So no, we haven't forgotten about COVID, that we'll still have, discussions about that as well. So, okay, well, I think we'll call it an evening. So thank you so much, everybody. It was great to be back with you, and I'm looking forward to seeing you again in the future.